My objectives are to tell you how to assess LV hypertrophy on cardiac MR. How do you differentiate various pathologies which can present with LV hypertrophy? But the main cornerstone of my presentation is that there are lots of cases. I'm just going to show cases. I'm going to ask you guys to contribute and try and make up your mind as to what do you think is the pathology. These are some of my references, so if you guys are interested, take a picture of this so you can also refer to them in future. Whenever I go and talk about cardiac MR to people who are new into cardiac MR, who are naive into cardiac MR, I show this slide. This is what echo is able to show today, that a patient has LV hypertrophy. We've got 4 different patients who've got different areas of LV hypertrophy, and that's where it stops with echocardiography or any other non-invasive modality, even with CT. But what is great about cardiac MR is that based on LGE pattern, we are able to tell that this patient is amyloid, this patient's got hypertrophic cardiomyopathy, this patient's got Fabry's, and this patient has got sarcoid. That's the beauty of LGE. But it's very good for presentations. In real life, it's not that clear cut. The other question comes is, do we really need to worry about LV hypertrophy? That's straightforward because the cases we get referred are hypertrophic cardiomyopathy most of the times. If you look at the MESA study, this was the study which looked at all patients who've had MESA. Nearly 5,000 patients had scans, and about 1.5% of that selected population had LV hypertrophy without any reason at all. Okay, they were not hypertensives, they were not athletes, they didn't have any cardiomyopathy. So there are people in the population who will have LV hypertrophy, and we wouldn't know why they have LV hypertrophy. Let's start with a case to show my point. This is a 55-year-old male who presented with increasing shortness of breath. There were heart failure symptoms with atypical chest pain. We've done a coronary, and the coronaries were normal. And this is what the cardiac MR shows. Okay, so the question for all of you is going to be, is this hypertrophic cardiomyopathy or not? That's going to be the question. Okay, so we can see here 4-chamber and 2-chamber, and I've also put in a 3-chamber view for you to look at the LVOT, to look at the mitral valve there. And then I've put up some cine short axis. Until here, we are very happy. We're going to be calling this hypertrophic cardiomyopathy, and then we do LGE. There is pericardial effusion. We could not null the myocardium. We just could not null the myocardium. And when we look at the parameters, LV wall thickness was 22 millimeters. T1 value was 1450. Normal is around 1250 for us. And the T1 look lockers that we do, the myocardium and the cavity was nulling at the same time. So there wasn't reversal of nulling, there wasn't normal nulling in there. So how many of you think this is HCM, hypertrophic cardiomyopathy? How many of you think this is amyloid? Okay, how many of you don't know? Good, honest people, well done. Okay, we also didn't know. Okay, there was one thing which I look back and I say, hey, every time you hear about LV hypertrophy, people talk about myocardial crypts. It's associated with hypertrophic cardiomyopathy. And then maybe there is some degree of LVOT narrowing across here, which is not very typical for amyloid. Okay, we did biopsies, skin biopsies, kidney biopsies, no amyloid anywhere. Okay, so absence of amyloid, kind of we think this is HCM. We don't know the answer. We don't have a genetic makeup. So, do we really need to worry? Yes, the answer is every time you have a look at a cardiac MR, first and foremost thing I train my fellows is to look for LV hypertrophy. Because if you know that this is LV hypertrophy, the next question you have to answer is it hypertrophic cardiomyopathy or is it physiological? Then you have to look at and say, fine, this is not physiological, this is not HCM, but what is the other pathology that you're looking at? And at the end, what is the clinical relevance? Let's start with few definitions. What is LV hypertrophy on cardiac MR in an end diastolic view on a short axis? On a short axis, the thickness should be more than 13 millimeters. You can stretch it till 15 millimeters, but it becomes hard when someone has 14 or 15 millimeter. You really don't know what it means. When it becomes more than 18 millimeters, you can be a little bit more confident that you're going towards hypertrophic cardiomyopathy. But anything between 13 to 18 is a tricky thing. So, what's a comprehensive way of assessing a case of cardiac MR with LV hypertrophy? First, say yes, there is hypertrophy. Second, what is the type of hypertrophy? Is it circumferential? Is it symmetrical? Asymmetrical? Does it involve the base? Does it involve the apex? That's the first thing that you describe. Next, look and see, is there any outflow tract obstruction? Not within the LV alone, look at aortic valve, look at the aorta also. Coarctation can lead to LV hypertrophy. So that's very, very important that you do that. Next, look at the LGE. Is there an LGE and what is the pattern of LGE? That is followed by looking at your mapping sequences and ECV to understand if this is normal myocardium or not. Look at wall motion abnormalities. Start looking at strain. Start looking at strain because that gives us a lot of information in cases where we are not 100% sure. Finally, genetic testing is very, very important. And of course, clinical data, you can't do anything about. So this is what we talk about strain imaging. Okay, this is basically, you don't have to do any new sequences. It's purely a software thing where you have the short axis, you have the 2-chamber and the 4-chamber. In the 2-chamber and 4-chamber, you get a parameter called as the global longitudinal strain or GLS, while you also get circumferential and radial strain, which is coming out of the short axis parameters. This actually allows you to pick up early LV dysfunction when the LV ejection fraction is normal. Okay, so when you have specific conditions where this will be very useful. T1 mapping, ECV, we've been hearing about it. It's very important for all of us to start looking at that. So now we're going to delve into more cases. This is a 35-year-old male. Echo showed LV hypertrophy. He came in with syncope and came in with a family history of sudden cardiac death. So everything fits in. Everything fits in. And this is the cardiac MR. Remember what I'd shown you in the other case? The first case? Something very similar here. But what you can see very nice in this case is systolic anterior motion of the anterior mitral leaflet or SAM with associated LVOT obstruction. Once you see that, you are almost home when it comes to hypertrophic cardiomyopathy diagnosis. In the short axis again, if you can see, the anterior mitral leaflet is going towards the LVOT and leads to obstruction. And on delayed enhancement imaging, typically hypertrophic cardiomyopathy will have patchy mid-myocardial enhancement in the hypertrophied segment. So this is typical HCM. In HCM, you need to look for types of HCM because you could have something which is like a mass. You could have something which is asymmetrical septal. This is the most common variety that we see, asymmetrical septal. You could have focal areas of hypertrophy, or you could have apical hypertrophic cardiomyopathy. Very important to not miss a finding like this, whereby you're seeing the mitral leaflet go in and block the LVOT, and this is what leads to sudden cardiac death in these patients. So this is SAM. Do not mention SAM in your reports as just SAM because it also means subaortic membrane for cardiologists. So do put a full form of it as a systolic anterior motion of the mitral valve leaflets. Different types of HCMs are also very useful because you could have mid-cavity obstructions. Other parameters which help you in telling this is HCM are myocardial crypts. Look for papillary muscle abnormalities. Elongation of the anterior mitral leaflet is an important finding which we report in all our HCM cases, and also an apicoseptal bundle whereby the papillary muscles comes all the way across to the mitral valve and attaches directly there. These are subtle markers which help you in differentiating hypertrophy because of another reason from hypertrophic cardiomyopathy. The enhancement pattern is variable but mid-myocardial patchy enhancement. Presence of SAM, presence of enhancement helps. Absence of these things really don't help. So if you've got a 16 millimeter thickness, you've got no SAM, you've got no LGE, does not mean it's not HCM. It still could be hypertrophic cardiomyopathy. So you have to look for that. So this is something we give in every report of ours. We talk about type of hypertrophic cardiomyopathy, what is involved, type of involvement. We also talk about severity of LV hypertrophy. Obstruction is there or not is important. If there are any other associated pathologies, and you have to quantify fibrosis. You have to quantify fibrosis because that is a independent prognostic feature for predicting sudden cardiac death and events in these patients. 15% is the published literature on this. When you look at different varieties, this is an apical hypertrophic cardiomyopathy where you see the apex is narrowed and blunted across, while on short axis you will see something similar where the cavity getting obliterated. This is one finding which is very useful in hypertensive hypertrophy and in aortic stenosis related hypertrophy. The cavity does not get obliterated. That something does not happen. So you can use that as a parameter. If you're seeing cavity obliteration, again, HCM becomes important. Let's look at this patient, 45-year-old male, increasing shortness of breath with another history of syncope and LV dysfunction, and we see this. Okay, circumferential hypertrophy. Also look out for RV hypertrophy. RV hypertrophy is not a feature of hypertensive heart disease. Okay, it will come in with hypertrophic cardiomyopathies or infiltrative diseases. This is a case where you can again see the SAM, the left atrium is dilated. Up till here, everything looks great. We are okay that this is hypertrophic cardiomyopathy, and then you see this kind of enhancement. Where you're seeing extensive enhancement along the septum, where almost half of the septum is not there. How many of you think this is HCM? How many of you think this is not HCM? How many of you don't know? Okay, the numbers have come down. So, okay, fine. This is HCM. Okay, the way I presented it, I just tried to confuse you, and I was thoroughly successful in doing that. This is HCM. You can get this extensive areas of enhancement. There was SAM in this patient. This is a patient, if you scan in under 4 or 5 years, you will see it as DCM. Everything will get thinned out and you will see it as DCM, and you wouldn't even know that they started off as a HCM. So important. A 25-year-old male, increasing shortness of breath, who is unable to do daily activities, and this is what the cardiac MR shows. Okay, and when you look at this, there is hypertrophy of the myocardium, but this myocardium doesn't look like a normal myocardium. Okay, and if I were to just show you some focal images, you need to understand that this kind of myocardium is called as the compact myocardium, and this is non-compact myocardium. And this is a case of LV non-compaction. Non-compaction can also mimic hypertrophy, and it's very important for you to be able to differentiate that. Sometimes you'll only get focal areas of non-compaction. The diagnosis on cardiac MR is based on the ratio of non-compact to the compact myocardium, a ratio of more than 2.3. Okay, but just one segment of non-compaction, please don't call it non-compaction. It's also important to understand the difference between a genotype and a phenotype. What you're seeing is a phenotype. We are seeing the presentation as a LV non-compaction. but the genotype or the gene responsible for this could be that of a hypertrophic cardiomyopathy. So when we report, we see that features are those of dilated cardiomyopathy with a non-compaction phenotype. That's the standard statement we use for LV non-compaction. We do not say this is LV non-compaction because the genotype can be very different in this. A young female who underwent echo and which said this is apical hypertrophic cardiomyopathy, and this is what the cardiac MR shows. You can see a lot of hypertrophy in the apex. You can see something involving on the RV side also and the LV side also, but there is a lot of fibrosis in the cavity, or if you think this is the muscle, then there is complete fibrosis. So this is a case of endomyocardial fibrosis. Excellent. It's very important to differentiate which is the myocardium and which is the fibrosis. And for that, it's very useful to do a CT scan and an early gadolinium enhancement imaging or perfusion imaging. Because if you do perfusion imaging at rest, you don't have to stress them. You will see the difference between the myocardium and filling of the cavity, which could be a thrombus within this. This is the biggest problem. This is a typical scenario where we really struggle. A patient has come, not a known hypertensive, but when our nurses did the blood pressure, this was 150 by 90. And he says, no, I'm just stressed. I've just come to the hospital. And this is the MR. We see concentric LV hypertrophy. There is no cavity, there is no cavity obstruction in here. LVOT is nice and open. There is no SAM. And you can see the cavity across here is also not obliterated. Short axis, concentric LV hypertrophy, no LGE. How many of you think this is HCM? Few of you. How many of you think this is hypertensive hypertrophy? Just because I gave you one BP measurement. Okay, so this is where the problem comes. How do you report this? What do you end up saying? Okay, and what we end up saying in this case is always that we need follow-up or a genetic testing, because there is no clear answer to say that this is X or this is Y. Typically, hypertensive hypertrophy should not be more than 15. You can still get more than 15 on the edges, but it should not be more than 15. Okay, it's concentric. It's not asymmetrical. T1 and ECV are essentially normal in these patients, but some of these cases can have mid-wall enhancement in there, which is a very, very non-specific. So if you see this, there's one corollary that you can take, which is an athlete's heart. If you see that, in India, we are very blessed. We are not yet scanning a lot of professional athletes, but this is something of a big private practice in UK and US, where you have to clear them off before they start doing any sports, because they will have LV hypertrophy. One thing to look for, which is very, very important, is LV cavity dilatation. You get LV cavity dilatation in athletes, which you don't tend to get in hypertrophic cardiomyopathy. So again, their thickness can go up to 16, 17 millimeters. T1 and ECV by definition should be normal. Okay, but sometimes they do go up. But one of the easiest things to do in this case, is detraining them. Now, when I say it's easy for us to put in our report and say, detrain them, which basically means don't do any physical activities, come back after 6 months. If it's an athlete's heart, the LV hypertrophy will go down. So it will get better. The athlete will practically kill you, because that's their whole life gone. For 6 months, if they don't do, there's $1 million contracts which they lose. So this becomes very important. The same corollary happens in India in high altitudes. People who come from high altitudes will have the same finding: symmetrical LV hypertrophy, LV dilatation. And it's important for us to be able to pick this up and tell them that this is what this is. Come down 6 months, low altitude, repeat, and if it gets better, fair enough, not a problem in that. Let's look at another case. A 34-year-old male again came in with syncope, known hypertensive, and this is what the MR shows. So again, circumferential LV hypertrophy. You can see something across here, which is actually, I will show you one more image to help you with that, but this wasn't SAM. It wasn't systolic anterior motion of the mitral valve leaflet. This is the delayed enhancement imaging, patchy areas of enhancement. How many of you think this is HCM? I'll tell you the options before you raise your hand. It'll be fair. HCM, this is hypertensive hypertrophy or something else. HCM, hypertensive, something else. You're all well trained in MCQs, but that something else in this case is this, which is supravalvular aortic stenosis. Okay, supravalvular aortic stenosis, which wasn't diagnosed, but he also had HCM. He also had HCM, he had a genetic done, so a double whammy of a disease. So you can see there is supravalvular aortic stenosis in this patient, and this basically was an accessory papillary muscle which was inserting abnormally in there. So it's very important to look at the entirety of the aorta in these patients before you make up your mind in your clinical practice. So your protocol should be good in that manner. This is one entity we don't see that often in India. If you do not have T1 mapping, you will not pick it up most of the times, whereby you will see circumferential LV hypertrophy. You will see ideally infralateral mid-myocardial enhancement, which is the typical appearance of Anderson-Fabry's disease, whereby in the septum you will see low T1 values, but areas of enhancement, which is the infralateral, you will see high T1 values or enhancement. This is something we don't see that much, but very important to have T1 values for this. So if you're procuring or upgrading your system, please don't question whether T1 is required or not. Get it. Next patient, a 48-year-old female, hypertensive again, with LV hypertrophy, and this is the cardiac MR. Circumferential LV hypertrophy, mild LV dysfunction, and now if you see the short axis, no cavity obstructions, no cavity obliteration, and this is the delayed enhancement images. Everybody know what this is? Good, couple of you can say that, good. So this is cardiac amyloidosis, whereby your T1 mapping and ECV are extremely raised in this patient, and you're seeing very nice circumferential subendocardial enhancement. It's all very nice on presentations. You should ask your technologist how much they struggle to get those kind of images. And I'll give you, okay, I've got 3 minutes. I'll give you an analogy. The first 3 cases that I did cardiac MR in India after I came back from UK were amyloid, first 3 cases. And I thought India has an amyloid epidemic. First case was amyloid. I said, okay, fair enough. Second case, amyloid. And it became third case. I said, oh, my technician doesn't know what he's doing. Okay, because I was trained in a place where the techs knew what they were doing. I'd left it to them. And then when I went and said, sir, I don't know what I'm doing. So we called all the 3. None of them were amyloids. Okay, so it's very important that you know your technique and get it properly. You can get atypical presentations, or these are kind of described presentations which can confuse you, but look out for pericardial effusions and pleural effusions in these patients. I think last 2 cases, I have a 32-year-old male, fever with acute heart failure, recent images from our department, and this is what we found. Circumferential LV hypertrophy, some hypertrophy of the RV, LV function is down, there is pericardial effusion, and this is the LGE announcement. Any guesses? Amyloid 1, okay, anything else? Non-compaction, okay, there is a non-compaction component. HCM, okay, good. So this is, you can see we all do not know what it is. We all disagree with each other. We will say what it is. This is Dannon's cardiomyopathy. This is Dannon's disease. So one of the things which we have realized is that if you see LV hypertrophy dilated with some components of LV non-compaction, of course, raise a genetic testing. In our report, we said this is not typical for hypertrophic cardiomyopathy. Other etiology needs to be considered. This came out to be Dannon's disease. Look out for other histories of skeletal dysplasias and mental retardation. That really helps. It is an important diagnosis because gene therapy is available for these patients. So don't stop there. Please make sure that you advise genetic testing and take it further. A 65-year-old male with arrhythmia. LV hypertrophy, maybe a little bit of RV hypertrophy. You can see biatrial dilatation. You can see that the patient has got arrhythmia while we are scanning him. And this is the 3-chamber view. And this is the pattern of enhancement. Patchy, patchy, patchy areas of enhancement. HCM, amyloid. Oh, very good, well done. Priya, well done. This is sarcoid. Look out for lymph nodes. Multifocal patchy areas of involvement is something very, very important that we need to look at, and it will help you in there. Raised T1 and ECV in acute phase especially is important. So one more slide coming where photos might be useful if you want to take. So this is kind of a summary of what we are talking about. And if you look at different pathologies, okay, busy slide, T1 value helps only in one etiology, in differentiate. The other etiology, it says there is inflammation, there is interstitial changes, but when it is down, helps with Fabry's disease. When you're looking at amyloid, you're looking for circumferential, circular subendocardial enhancement, and look for atrial involvement. That also helps us in saying that this is amyloid. Another thing which really helps is, of course, sarcoid, which you've seen, but this is the more important point. If you end up seeing something which is an athlete who has got LV hypertrophy without a SAM, without a cavity obstruction, detraining really important. And look for cavity enlargement in these patients because that is also very, very useful for us. Looking at the various parameters as a summary, when you're looking different LV hypertrophy, aortic stenosis can also give you patchy areas of enhancement, Fabry's, infralateral, amyloid almost circumferential, mid-myocardial hypertrophic cardiomyopathy. So, in summary, identifying LV hypertrophy is number one, which I think if you go through a stepwise process, you will be able to do it. 13 millimeter is the ballpark figure, end diastole, which is important. Second, look and see if there is any outflow tract obstruction along the entire outflow tract. Third, you have to say, is this hypertrophic cardiomyopathy or is this physiological? Physiological, hypertensive, high altitude, or a patient who has a professional athlete. Then you have to go and look at the pathological causes. Look at the LGE, use the technology, look at T1 mapping, and you will be able to then differentiate a lot of pathologies. Absence of SAM, absence of LGE does not exclude HCM. Okay, and if we do 100 cases of suspected HCM, about 55 to 60 are HCM, about 20 to 30 are non-HCM, and about 10 we do not know. Okay, and please, I'm very honest when I say I do not know. I say this is not typical HCM. You need to do something more. So thank you very much for patient listening.
Thank you, Dr. Vimal.